Hello, everyone.
And welcome to a brand new series we're starting right here on the Deep Dive. We're going to be tackling the USMLE Step 1 free 120 practice questions.
That's right. And while our audience traditionally includes folks prepping for Step 1, Step 2, and Step 3, this deep dive into Step 1 stuff, it's actually super relevant for everyone.
Absolutely. Step 1 has changed, hasn't it? It's way more clinical now.
It really has.
So many concepts, the question styles, the pathways you need.
Yeah.
It just keeps popping up on Step 2 and Step 3. These basic sciences are like the bedrock.
Definitely. So our goal with this series, starting right now, is to go through these 120 questions and not just, pick the right answer.
Right, more than that.
Yeah, we want to really break down the vignette, pull out the clues, get the why behind it, the mechanism, the pathophysiology, risk factors, how it looks clinically, aiming for that deeper level.
Okay, let's unpack this then. First question up.
Huh.
We have a 14-year-old boy. He's obese. He's had this right knee pain for about a month, getting progressively worse, and it flared up today. Hurts when he walks, better when he sits.
Weight-bearing pain.
Yeah. And he did start marching band practice recently, like 2 weeks ago, walking a mile a day. But importantly, his symptoms started before that.
Okay. Timing matters.
Past history. Broken tibia fibula when he was 8. Asthma. Uses an inhaled steroid and albuterol. Family history has type 2 diabetes and osteoporosis.
Got it.
Then the physical exam. Clearly obese, BMI is 31, 98th percentile. He's got that hyperpigmented, thickened skin on his neck, acanthosis nigricans.
Sign of insulin resistance, often linked to obesity.
Right. Tenderness over the anterior right hip. And his motion there is limited abduction, internal rotation, flexion are all restricted. Left side's normal.
Okay, so adolescent boy, obese, hip pain, limited motion, worse with weight bearing.
Exactly. So
Yeah.
the question's asking about the most likely risk factor here.
Right, this pattern, it's pretty classic for a certain group of hip problems in kids, and there's kind of a cheat code for exams based on age.
Oh, yeah. Tell me about that.
So if you see a newborn with hip issues, you're thinking DDH, developmental dysplasia of the hip, sometimes called flat acetabulum.
Okay, newborn DDH.
If it's a younger child, say under 10, think leg calf perthes. That's the osteonecrosis of the femoral head.
Got it. Under 10, leg calf perthes.
But when you get to an adolescent, usually over 10, especially if they're obese and they have hip or even knee pain like this patient, slip capital femoral epiphysis, SCFE, should be right at the top of your wrist.
The CFE.
Right.
And that x-ray finding. The ice cream slipping off the cone.
Perfect analogy. It sticks in your head. So our patient is 14, fits the age.
Yep.
And he's significantly obese, BMI 31. Those two things, age over 10 and obesity, are the big risk factors for SCFE. And the USMLE loves emphasizing obesity for this one.
So what about all that other stuff? The family history, asthma meds, that old fracture, the marching band. Are they just distractors?
Pretty much in this case. The T2DM and osteoporosis history, not really direct risks for SCFE. Inhaled steroids. Very unlikely to cause the kind of bone issues systemic steroids might. Probably irrelevant.
And the old break?
That was years ago. Different bone, not directly related to a slip at the hip's growth plate now, though, past joint problems can sometimes predispose to arthritis much later.
Right.
And the marching band. His pain started before that. Activity might make it hurt more, sure, but it didn't cause the slip. It really comes down to his age and especially his weight.
Okay, so here's where it gets really interesting. Why does the weight matter so much? What's actually happening?
It's basically mechanics. During that adolescent growth spurt, the growth plate, the physis up at the top of the femur, is still mostly cartilage. It's weaker than the surrounding bone. In someone who's obese, all that extra weight puts a ton more shear force across that vulnerable plate. It's like pushing sideways on something fragile.
I see.
The weight literally causes the epiphysis, the ball part of the hip joint, to slip backwards and downwards off the neck of the femur. Mechanical stress on a weak spot.
Got it. Mechanical strain on developing bone. Makes sense.
Exactly.
Okay, let's completely shift gears. Question 2. 14-year-old girl this time.
Okay.
She's had these red bumps on her skin for 3 months. Says they don't itch, don't hurt, but she finds them embarrassing. No medical history, no meds, vitals normal. Exam just mentions a photo showing a red goosebump-like appearance.
All right, key features. Red, goosebump-like bumps, 3 months duration. And critically, not itchy or painful.
That not itchy part feels really important for skin stuff.
It absolutely is. Huge clue. It helps rule out a lot of common things right away, like eczema, usually super itchy, often scaly, red, doesn't look like goosebumps.
Right.
Folliculitis, that's inflammation around hair follicles, looks different, probably wouldn't sit there unchanged for 3 months.
Makes sense.
Hidradenitis suppurativa, that's inflammation of sweat glands, usually armpits or groin, chronic, often drains. Totally different picture.
Okay.
And urticaria hives, the hallmark is itchiness. She specifically says these aren't itchy, so hives are out.
Okay, so non-itchy, red goosebump look, been there for months.
Sure.
Sounds a lot like keratosis pilaris.
Fits perfectly. Keratosis pilaris, or KP. The name kind of tells you keratosis means keratin.
Ah.
The underlying issue is too much keratin building up and plugging the hair follicles. That's what causes those little bumps.
I think the source mentioned it runs in families.
It can, yeah. Often autosomal dominant inheritance. It also tends to get worse in cold, dry weather, like in winter.
Where do you usually see it?
Most common spots are the back of the upper arms, thighs, sometimes the cheeks or the back.
Is it serious?
Mostly just a cosmetic nuisance, really, but it can definitely bother people. Treatment is usually about moisturizing well, maybe using lotions with exfoliants like urea or lactic acid. Sometimes lasers are an option. You should definitely look up pictures if you haven't seen it. Makes it easy to spot on an exam.
Good tip. All right, next patient, different system. Question 3. 50-year-old man, complaining of increasing daytime sleepiness for 2 months. History of obstructive sleep apnea, OSA, but he uses his CPAP only intermittently.
Uh-oh. Intermittent use. Not ideal.
Not at all. And he's severely obese. 5'7", 400 pounds.
Yeah.
BMI is 63.
Wow, okay. BMI 63.
His pulse is 100. Exam shows this gray-blue tinge to his lips, earlobes, nail beds. Cyanosis. Definitely.
Yeah.
His ABG is on room air. pH 7.31. PCO2 is 70. PO2 is 50.
Whoa. Okay, let's break that down. pH 7.31, that's acidotic.
Right.
PCO2 of 70, that's really high.
Yeah.
Respiratory acidosis. And the PO2 of 50 confirms he's significantly hypoxic.
So severe obesity, OSA history, daytime sleepiness, and daytime hypercapnia. This isn't just OSA anymore, is it?
No, exactly. This has progressed. This is obesity hypoventilation syndrome, OHS. It's basically when the obesity and chronic sleep disorder breathing lead to chronic respiratory failure with CO2 retention even when awake.
Okay, OHS. And those ABGs. Respiratory acidosis. What about compensation?
Well, his body will try to compensate for the chronic high CO2 by retaining bicarbonate through the kidneys, so metabolic compensation. One of the answer options might be decreased serum bicarb, but that would be wrong. We'd expect his bicarb to be high, or at least trying to get high.
Got it. And he's chronically hypoxic, PO2 of 50. What does the body do in response to chronic hypoxia?
That's the key connection for the likely additional finding. Chronic hypoxia tells the kidneys, hey, we need more oxygen carriers.
So they pump out EPO.
Exactly. Erythropoietin. EPO drives the bone marrow to make more red blood cells. So someone like this with chronic hypoxia from OHS, you'd expect to find an increased hemoglobin concentration, increased hematocrit, polycythemia.
Secondary polycythemia. Makes sense. And other things cause that too, right? Like bad COPD.
Yep, severe COPD, cystic fibrosis, pulmonary hypertension, even some congenital heart defects. Anything causing long-term hypoxia can trigger that EPO response.
Okay, so increased hemoglobin is likely. What about his lung volumes? With all that weight, does his total lung capacity go up?
No, actually the opposite. It's a common misconception. Severe obesity causes a restrictive lung pattern, not obstructive.
Restrictive? How?
Think about the chest cavity as a box. You've got the lungs inside, but below the diaphragm, you have the abdomen. In severe obesity, the sheer mass of abdominal contents pushes up on the diaphragm.
Less room for the lungs to expand downwards.
Exactly. It physically restricts lung expansion. So lung volumes like total lung capacity, TLC, functional residual capacity, FRC, expiratory reserve volume, ERV, they all go down.
So compliance decreases, elastance increases, making the lungs stiffer, effectively.
Generally speaking, yes, that's the pattern in restrictive disease. It's a bit complex comparing directly to obstructive, but the key takeaway for obesity is decreased volumes due to restriction. Things like DLCO and AA gradient depend on the specifics too.
Okay, and the heart. Chronic hypoxia, high pulse. Does that mean left ventricular hypertrophy, LVH?
Nope, wrong ventricle.
Yeah.
Think about the consequences of chronic hypoxia and hypercapnia on the pulmonary circulation. It causes pulmonary vasoconstriction.
Leading to pulmonary hypertension.
Right, and pulmonary hypertension puts strain on the right side of the heart, so you'd expect right ventricular hypertrophy and eventually right heart failure, what we call cor pulmonale, heart failure due to a lung cause.
Okay. LVH is more from things like systemic high blood pressure or aortic stenosis, putting pressure on the left side.
Precisely. So for this guy, the OHS and chronic hypoxia point straight to increased hemoglobin polycythemia as the most likely associated finding. Classic step 1 multi-system thinking.
Okay, question 4. A 32-year-old man.
Younger guy.
Yeah. 1 day of coughing up blood hemoptysis, 2 days of shortness of breath and ankle swelling, edema. And for the 2 weeks prior, he felt really tired, noticed his urine was dark.
Okay. Lungs and kidneys involved.
Definitely. BP is way up, 110, 15, 110. O2 sat is low, 91%. Exam shows crackles in his lungs, pitting edema in his ankles.
Pulmonary edema, peripheral edema.
Labs show anemia, high BUN, and creatinine, indicating kidney failure. And the urinalysis. Lots of red blood cells, dysmorphic red cells, and even some rare red blood cell casts.
Okay, that urinalysis dysmorphic reds, RBC casts, that just screams nephritic syndrome, glomerular damage.
Absolutely.
Yeah.
And they did a kidney biopsy. Shows crescentic glomerulonephritis.
RPGN, rapidly progressive glomerulonephritis, very serious.
And the immunofluorescence finding is key. Linear deposition of IgG along the glomerular capillaries.
Okay. Linear IgG, that's the money finding.
So the question asks what antigen his antibodies are likely targeting.
Right. So pulmonary symptoms, hemoptysis, renal failure, nephritic syndrome, RPGN, and that specific linear IgG deposition on biopsy. This is the classic picture of Goodpasture syndrome.
Goodpastures. And that's caused by autoantibodies against
Against the glomerular basement membrane, or GBM, specifically against a component of type IV collagen,
which type IV collagen chain?
the alpha-3 chain. Anti-GBM antibodies target the alpha-3 chain of type IV collagen.
Okay, and why does that hit both the lungs and the kidneys?
Because that specific type IV collagen chain is found in the basement membranes of both the glomeruli in the kidneys and the alveoli in the lungs.
So the antibody attacks both places. Makes perfect sense.
Exactly. Leads to glomerulonephritis and alveolar hemorrhage. Goodpastures usually affects the lower airways, by the way.
Good point. So how do we distinguish this from other things that cause lung and kidney problems, like, say, Wegener's?
Good question. Wegener's, now called granulomatosis with polyangiitis, or GPA, is an ANCA-associated vasculitis. It can cause pulmonary renal syndrome and RPGN, but a few key differences. GPA often involves the upper airway to sinusitis, nose problems, and critically, the kidney biopsy in GPA is usually post-immune, meaning few or no immune deposits, or sometimes granular deposits, not linear IgG.
Okay, so upper airway involvement and post-immune biopsy point away from Goodpastures. What about Alport syndrome? That involves collagen too, right?
Right, but Alport's is different. It's a genetic defect in the alpha-5 chain of type IV collagen, not an autoimmune attack on alpha-3. It causes kidney disease, often nephritic, but it's usually associated with hearing loss and eye problems too. No autoantibodies involved.
Got it. And things like lupus.
Lupus nephritis can definitely happen, but the immunofluorescence usually shows granular deposits, often multiple types, a full house pattern, not isolated linear IgG. Antiphospholipid antibodies cause clotting issues, not this picture.
So that linear IgG finding is really specific for antibodies against the alpha-3 chain of type IV collagen.
It really is. It's the defining feature of Goodpasture syndrome. Understanding that target explains the whole clinical picture.
Okay, let's switch to pediatrics again. Question 5. A 5-year-old girl,
All right.
2 days of fever, urinary urgency, painful urination. Sounds like a UTI.
Classic UTI symptoms, yeah.
But here's the kicker. She's had 4 similar episodes in the past year. Recurrent UTIs.
Recurrent UTIs in a young child. That's a big red flag. You have to think about underlying anatomy.
Exactly. And they did a renal ultrasound. It showed one large U-shaped kidney.
Okay, U-shaped kidney. Sounds like a horseshoe kidney.
Yep. So the question asks about the most likely embryologic cause of her condition.
Right. So horseshoe kidney often predisposes to UTIs, possibly due to abnormal drainage or urine stasis. Now, embryologically, how does it form?
What's the key step?
The most specific answer, usually the one they're looking for, is the fusion of the inferior poles of the two developing kidneys, the metanephrae.
Inferior poles fuse. And what happens then?
As the kidneys normally ascend from the pelvis up towards the abdomen during development, that fused lower part gets caught underneath the inferior mesenteric artery. The IMA basically blocks their ascent.
So they get stuck low down and fuse.
Exactly. That leads to the horseshoe shape and the lower position. The source also mentioned an association with Turner syndrome, which is good to remember.
Okay. What about other embryologic possibilities, like failure to rotate?
Kidneys do rotate medially as they ascend, but failure of rotation isn't the cause of the fusion. Failure of ascent is a consequence, but the fusion of the inferior poles is the primary embryologic event causing the horseshoe shape itself.
And failure of one ureteric bud.
That would cause problems with one kidney, like renal agenesis or hypoplasia, not the fusion of two kidneys into a U shape.
So for these embryology questions, you need the most fundamental defect.
Yeah, they often want the root cause, the specific step that went wrong. Here, it's the fusion of the inferior poles during ascent.
Got it. Okay, question 6. We've got a 78-year-old man. He's on warfarin because he has a mechanical aortic valve.
Okay, needs anticoagulation.
Right. He was recently hospitalized for a non-tuberculous mycobacterial infection. Started Cipro and rifampin a week ago.
New meds. Cipro and rifampin.
He also takes HCCZ and lisinopril for hypertension. 4 days ago, they doubled his warfarin dose.
Doubled the dose. Okay.
He mentions trying a healthier diet, still drinks his usual 2 beers a day, labs. 4 days ago, PT was 11.0, PTT was 29. Today, after doubling warfarin, PT is 11.2, PTT is 27.
Wait, so they doubled his warfarin and his PT barely budged and his PTT actually went down slightly.
Exactly. That's the puzzle. Why aren't his PT-PTT increasing like they should?
Right. Warfarin inhibits vitamin K epoxide reductase, blocking factors 2, 7, 9X, proteins C and S. It should definitely increase both PT and PTT. Doubling the dose should have a significant effect.
So something is counteracting the warfarin.
Yeah, let's look at those new meds again. Ciprofloxacin and rifampin.
Rifampin. Isn't that a major enzyme inducer?
Bingo. Rifampin is a potent inducer of cytochrome P450 enzymes, especially CYP enzymes that metabolize warfarin, like CYP2C9.
So the rifampin is basically making his liver chew through the warfarin much faster.
You got it. It revs up the metabolism. So even though he's taking double the dose, his body is clearing it so quickly that the drug levels aren't rising enough to increase his PT-PTT. It's a classic, really important drug interaction.
What are some other common inducers to know?
The classic mnemonic often includes grisafulvin, carbamazepine, phenytoin, barbiturates, rifampin itself, St. John's wort, and chronic alcoholism.
Okay, let's roll out the other ideas. Increased protein binding.
Not really plausible explanation for lack of effect after a dose increase. Maybe a transient dip, but doubling the dose should overcome that.
Cipro killing gut flora. Gut flora make vitamin K.
Right, but if Cipro killed the vitamin K producing bacteria, you'd have less vitamin K around. Less vitamin K means warfarin would have an enhanced effect. You'd expect higher PT-PTT, maybe even bleeding. Opposite of what we see.
Good point. His alcohol intake.
He says it's his usual amount. While chronic heavy drinking can induce enzymes, the acute introduction of rifampin, a known potent inducer, is a much stronger explanation for this sudden change.
And the healthier diet, maybe more leafy greens with vitamin K.
Possible, but the vignette is vague. Healthier diet doesn't automatically mean tons more vitamin K. And again, rifampin's effect is so significant, it's the most likely culprit here.
Definitely highlights how crucial it is to check for drug interactions, especially with warfarin.
Absolutely. USMLE loves testing non-adherence and interactions. Here, the rifampin induction is the key.
Okay, question 7. 32-year-old man again. 2 weeks of fever and throat pain.
Fever, sore throat, okay.
BMI is normal, 21. Vitals. Tachycardic, pulse 110, a bit hypotensive. BP 9068. Physical exam shows scattered enlarged lymph nodes neck. Axilla inguinal 204 centimeters. Bilateral tonsillar exudate. No ulcerations mentioned.
So fever, pharyngitis, generalized lymphadenopathy. Sounds like mono, right?
Looks like it.
Yeah.
Here are the twists. Labs show low hemoglobin, low white count, low platelets. Pancytopenia, or at least cytopenias across the board.
Oh, okay, cytopenias. That's unusual for typical mono.
And the heterophile antibody test in the monospot is negative.
Negative monospot and pancytopenia. Okay, this is likely not typical EBV mononucleosis.
Right. What else could cause a mono-like picture? What about bacterial pharyngitis?
Like strep or gonococcal. Usually those cause a high white count, leukocytosis, not cytopenias. Gonococcal pharyngitis is usually just the throat. LGV involves nodes, but typically inguinal and not usually these widespread cytopenias.
So mono-like illness, negative monospot, plus those cytopenias. What fits in that picture?
The highest yield diagnosis to consider here is acute retroviral syndrome, acute HIV infection.
Acute HIV.
Yeah. The initial infection can present exactly like this. Flu-like or mono-like symptoms, fever, sore throat, lymphadenopathy, and importantly, cytopenias can be a feature of acute HIV. The negative monospot fits too.
What else causes monospot negative mono? CMV.
CMV is another big one, yeah. Cytomegalovirus definitely causes a heterophile negative mono-like illness. It wasn't listed as an option in the source, but it's a key differential in real life and on exams. But given the options usually presented, and especially with those cytopenias, acute HIV is a very strong possibility here.
Crucial diagnosis to consider. The cytopenias really push you away from typical EBV or bacterial causes.
Absolutely. They're a major clue in this vignette.
Okay, question 8. 50-year-old man. For 2 months, headaches and shortness of breath when he exerts himself.
Headaches, exertional dyspnea. Okay.
History of hypertension, treated with HCTZ for 2 years. But his BP today is 180/105.
Whoa. Very poorly controlled hypertension, despite medication.
Yeah. He asks what's most likely to be seen on his eye exam, the ophthalmoscopic exam.
All right, so severe, chronic, uncontrolled hypertension, it damages blood vessels everywhere. And the retina is a place we can directly see those vessels.
And there's a classic finding you look for with hypertensive retinopathy.
There is. The most characteristic finding, especially with this chronicity and severity, is arteriovenous nicking, or AV nicking.
AV nicking. What exactly is that?
So the high pressure makes the retinal arteries stiff and thick, like atherosclerosis. Where one of these hardened arteries crosses over a retinal vein, it can compress the softer vein underneath.
Squashes it.
Yeah, basically. It makes the vein look narrowed or nicked right where the artery crosses, kind of like an hourglass shape in the vein at that point. It's a direct sign of hypertensive vascular damage. This can happen with any cause of severe chronic hypertension, not just essential HTN.
So if you see severe hypertension on the exam and they ask about eye findings, AV nicking is often the answer they want.
It's a very common and direct consequence. So yes, it's a high-yield association.
Let's quickly check the other options. Melanocytes in the uvea.
Just pigment cells. Irrelevant.
Optic neuritis.
That's inflammation of the optic nerve, often seen in MS. Painful vision loss, usually one eye, not hypertension related.
Posterior subcapsular cataracts.
Usually related to aging, diabetes, or chronic steroid use, not a direct result of high blood pressure itself.
Tractional retinal detachment.
That's more classic for advanced diabetic retinopathy, where abnormal blood vessels pull on the retina, not typically caused by hypertension alone.
So severe hypertension points strongly to AV nicking as the direct vascular consequence visible in the eye.
Exactly. Stick with the most direct link when you see a classic presentation like this.
Okay, question 9. 65-year-old woman. History of rheumatic mitral valve disease.
Okay, risk factor for atrial fibrillation and embolic events.
You called it. Sudden onset 30 minutes ago of right-sided weakness and inability to speak.
Stroke symptoms, sudden onset.
Neuro exam. Weakness in the right lower face, trouble swallowing. Strength is 35 on the right side. She can understand what's said to her, but she cannot repeat things or answer questions.
Okay, let's break down those deficits. Right-sided weakness.
Means the problem is in the left hemisphere's motor pathways.
Right. And the speech understands. Okay, so Wernicke's area seems relatively intact, but can't produce speech, repeat, or answer.
Sounds like Broca's aphasia. Expressive aphasia.
Exactly. And Broca's area is typically in the dominant hemisphere, which is usually the left for most people.
So left motor deficit, left Broca's area deficit.
Points strongly to a lesion in the territory of the left middle cerebral artery, the left MCA. It supplies those lateral parts of the hemisphere, including motor cortex and Broca's area.
And her ECG confirms AFib.
Right. So the likely mechanism is cardioembolic stroke. Clot formed in the fibrillating left atrium, probably worsened by the rheumatic valve disease, traveled up and lodged in the left MCA. Very common scenario.
And the question showed a circle of Willis diagram, asking which artery was occluded. The left MCA was labeled D.
Correct. So identifying the stroke syndrome, localizing it based on deficits, linking it to the vascular territory, and then finding that artery on the diagram, that whole sequence is classic USMLE. You need to know that circle of Willis anatomy.
Yeah, the vertebrals forming the basilar, PCAs coming off, ICs giving rise to the ACAs and MCAs, PCMs connecting posterior to anterior, ACOM connecting the two ACAs.
And that ACOM, as the source mentioned, is a super common spot for berry aneurysms.
This really raises an important question. How does knowing that circle of Willis anatomy help you diagnose strokes just from the symptoms?
Because, like we just did, specific deficits map to specific brain regions, and those regions are fed by specific arteries. If you know the functional map and the vascular map, you can predict the blockage site just by listening to the patient's story and doing the exam. It's the core of clinical neurology.
Fascinating connection between anatomy and function.
It really is.
Okay, last one for today, question 10. 51-year-old man. He's got a 10-year history of GERD, and they suspect he has Barrett's esophagus.
Okay, chronic GRD, potential complication.
He's on omeprazole, PPI, maximum dose. But he says around the Christmas holidays, it just doesn't seem to work.
Specific timing again. Only fails during the holidays.
Yeah. And he volunteers that during the holidays, he prides himself on having a large appetite and holding his liquor.
There it is. Large meals, alcohol, classic GERD triggers.
So the medication works fine most of the year, but fails specifically when he admits to lifestyle choices known to worsen GERD.
Exactly. The omeprazole is likely doing its job inhibiting the proton pump. But his holiday habits, big meals stretching the stomach, alcohol relaxing the lower esophageal sphincter, and maybe stimulating acid are probably overwhelming the medication's effect.
So what's the most appropriate initial action for the doctor?
Given that very strong clue about holiday behavior linked to symptom breakthrough, the most logical first step is to directly address that. You need to ask him specifically about his diet and drinking habits during that holiday period.
Explore the likely trigger.
Precisely. Assess his understanding and adherence to lifestyle modifications, which are crucial for GERD control, even when on meds.
What about explaining the dangers of reflux with Barrett's? Isn't that important?
It's absolutely important for his overall care and long-term risk management, but it's not the best initial action to figure out why his medication is failing right now during this specific time. You need to investigate the cause of the immediate problem first.
Okay. Order an upper endoscopy?
Probably not needed right now. The PPI works most of the time, suggesting the underlying Barrett's hasn't suddenly worsened drastically or formed a major stricture. The problem seems triggered and intermittent.
Refer him to GI.
Again, probably not the first step. The primary doctor should explore the obvious lifestyle trigger first. Referral comes later if addressing that doesn't work or if other red flags appear.
And just switching him from omeprazole to another PPI, like pantoprazole.
Unlikely to help if the issue is massive lifestyle triggers overwhelming any PPI. They work similarly. You have to address the root cause of the breakthrough symptoms.
Makes sense. It really comes back to basics, asking the patient about adherence, not just to meds, but to lifestyle advice too.
Totally. If we connect this to the bigger picture, managing chronic disease effectively means looking beyond the prescription pad. Patient behavior, diet, habits, they're often just as critical as the medication itself, especially for something like GER. You gotta ask.
Well, that wraps up our first 10 questions from the Step 1 Free 120. We've covered quite a bit of ground peds: derm, palm crit, nephro, embryo, pharm, ID, ophthalm, neuro-GI.
Yeah, a real tour. And as we said at the start, the kind of thinking involved linking pathophysiology, risk factors, labs, clinical signs, that's essential stuff. Whether you're studying for Step 1, 2, or 3, it all builds.
We'll definitely keep going with this series in future deep dives, working through the rest of these questions and exploring more of these core concepts.
And maybe a final thought for you, the listener, to chew on until next time. Think about how something seemingly abstract, like the embryology of how a horseshoe kidney forms, can directly lead to very real clinical problems, like recurrent UTIs decades later. How does that very early development influence lifelong health risks? Something to ponder.